Well, welcome back to this opinion leader workshop in non-small cell lung cancer. Earlier, Dr. Alicia Sequist covered EGFR and MET and HSP90, and now Dr. Alice Shaw from Massachusetts General Hospital and Harvard Medical School is going to enlighten us about ALK, ROS1, RET, and KRAS. So Alice, thanks so much for being here.
Thank you, Jim, and thanks to everyone for joining in. We'll be talking about 5 targets today: ALK, ROS, RET, BRAF, and KRAS. And let's first start with ALK. ALK is very well known to everyone probably, so I'll just briefly review ALK rearrangements as oncogenic drivers. As many of you may recall, we've known about ALK for many years in the context of a different cancer, anaplastic large cell lymphoma. But ALK was rediscovered just about 6.5 years ago in 2007 by a group in Japan, and they identified ALK rearrangements in a small subset of patients with non-small cell lung cancer and demonstrated that ALK rearrangements then led to the formation of ALK fusion proteins, which functioned as potent oncogenic drivers. Since then, there has been a lot of work done around the world to characterize the different ALK rearrangements that occur in lung cancer. And shown here are most of the known ALK rearrangements that have been reported. As you can see, the most common ALK fusion in non-small cell lung cancer is EML4 ALK. But there are other ALK fusions as well: KIF5B ALK, KLC1 ALK, and TFG ALK. What's common to all of these fusions is that they involve fusion of a portion of the ALK gene that includes the tyrosine kinase domain of ALK to differing portions of 5' end partner protein like EML4. And this then leads to expression and constitutive activation of the ALK tyrosine kinase. So to date, there have now been 3 large studies of crizotinib, the first ALK inhibitor to be tested in the clinic, and these studies all go by the name Profile. So the phase 1 study of crizotinib is Profile 1001, and then there were follow-up registration studies of crizotinib, the phase 2 Profile 1005 study, and then the phase 3 Profile 1007 study. This is a summary of the results from those 3 large profile studies. I've just highlighted in purple the phase 2 Profile 1005 study because that data was most recently updated. That study is very large now with over 1,000 patients, but at the time, a few months ago when the data was updated, the data was presented for 765 patients. And as you can see, just quickly looking at this table, the efficacy data is quite similar across all 3 studies, with a high response rate in the 50 to 60% range and very impressively long durations of response. I'm going to focus for the next couple slides on the phase 3 study, which is the first randomized trial of crizotinib. So this trial was a global study, and this was for patients who were ALK rearranged using the standard FISH assay. All of these patients were in the second line and so had failed prior platinum-based chemotherapy. Patients had an ECOG performance status of 0, 1, or 2, and we did allow patients to enroll with brain metastases. The enrollment target was 318. We actually over-enrolled at 347, and patients were randomized 1-to-1 to receive either second-line crizotinib or a standard second-line chemotherapy like pemetrexed or docetaxel. I should note that those patients who were randomized to chemotherapy were allowed to cross over to receive crizotinib at the time of progression. And this was done through the companion phase 2 study, Profile 1005. The primary endpoint of this study was progression-free survival. So the study met its primary endpoint, and I think that was not too surprising to anyone given the strength of the single-arm data from the phase 1 and 2 trials. These are the progression-free survival curves showing that crizotinib is superior to either pemetrexed or docetaxel, with a median PFS of 7.7 months compared to a median PFS with chemotherapy of 3 months. And here the hazard ratio is 0.49 with a highly statistically significant p-value. I didn't show the other efficacy parameters that we looked at, including response rate. Those are also very positive. But I did want to highlight another endpoint, a secondary endpoint, which was patient-reported outcomes. And I think this is one of the more important aspects of this study, because for the first time here we're looking at patients' symptoms as well as what they reported for quality of life. And so this is a summary of that data showing that crizotinib, those patients who received crizotinib reported a significant improvement in symptoms, disease-related symptoms, as well as in global quality of life compared to those patients who had received chemotherapy. So currently, there are actually two profile studies of crizotinib that are ongoing. This is profile 1014, which is the first-line study of crizotinib. And here, ALK-positive patients are randomized again 1-to-1 to receive either frontline crizotinib or to receive a frontline platinum pemetrexed regimen up to 6 cycles with no maintenance chemotherapy. And again, this trial does allow patients to cross over from chemotherapy to crizotinib. This study actually has reached its accrual, and results may be presented this year at ASCO, so stay tuned for those results. There's a similar first-line study of crizotinib going on in Asia. This is profile 1029, very almost identical design, except this will recruit only in Asia. As shown here, the breakdown from different Asian countries. Again, randomization to frontline crizotinib or frontline chemotherapy with a primary endpoint in both studies being progression-free survival. So we've learned a lot about crizotinib and its role in ALK-positive lung cancer. And actually, I don't have time to go through all of the data on resistance to crizotinib, but there have been many studies from around the world trying to identify mechanisms of resistance to crizotinib. And Dr. Sequist reviewed some of the broad classes of resistance mechanisms, and those apply in the setting of ALK-positive lung cancer as well. Given that patients do relapse on crizotinib, typically within 1 to 2 years of starting, there has been a huge movement to try and develop more potent ALK inhibitors and ALK inhibitors that can overcome resistance in patients. And so shown here are 9 next-generation ALK inhibitors that are currently in clinical trials. And they're all at different stages of development. You can see some are very, very early on, just starting in phase 1, like the new Pfizer drug, PF6463922. And others like ceritinib or LDK378 are very advanced and are currently in phase 3 studies. Again, because of the limited time, I'm only going to focus primarily on the 2 most advanced ALK inhibitors, ceritinib or LDK378 and alectinib. So ceritinib is second-generation ALK inhibitor developed by Novartis. It's much more potent than crizotinib and also more selective than crizotinib. It does not have any anti-MET activity the way crizotinib does. And a phase 1 study of ceritinib was launched about 3 years ago in patients with advanced cancer harboring any type of ALK alteration. And as you can imagine, most of the patients who enrolled did have ALK-positive lung cancer, and some had received prior crizotinib, so they were crizotinib resistant, and some had not received prior crizotinib. So this is a waterfall plot summarizing the data from that phase 1 trial. And shown here are patients with ALK-positive lung cancer who had enrolled on ceritinib and had received doses of 400 milligrams up to the maximum tolerated dose of 750 milligrams once daily. Shown here are 104 evaluable patients, and I think as you can see very clearly from the waterfall plots, most patients did have a response to ceritinib, and that included patients who had become resistant to crizotinib, as shown by the blue bars, as well as patients who had never seen crizotinib, shown by the yellow bars. In fact, the confirmed response rate in all of these patients was close to 60%, and that was true for that cohort of patients who had received prior crizotinib. So a pretty impressively high response rate given that these patients had failed the first-generation ALK-TKI crizotinib. Median progression-free survival at the time we reported this data at ASCO was in the 8-month range. So again, just confirming that these responses not only were dramatic in many cases, but also quite durable. This is data from a different ALK next generation inhibitor. This is one that was originally developed by Chugai, named AF802, and has now been taken over by, this drug has been now licensed by Roche and is being developed as alectinib. I should note that both ceritinib as well as this drug, alectinib, they both have FDA breakthrough therapy designation, and it's primarily based on the data that we're showing you today. This is data that Dr. Wu presented at ESMO last fall, looking at the efficacy of alectinib in patients with ALK-positive lung cancer who had previously received crizotinib. And again, similar to what we've seen with ceritinib, alectinib was associated with a fairly high response rate, about 55% in patients who had been on crizotinib before. And in the bottom part of this graph is shown the durations of response, which also are quite long. So again, more mature data on this compound will be presented at ASCO this year. I did want to note that with this drug, as well as with ceritinib and some of the other next-generation ALK inhibitors, we have started to see some very nice responses in the brain. As many of you know, patients with ALK-positive lung cancer frequently relapse in the brain when they're on crizotinib. That is the most common site of relapse for these patients. And we've been very excited to see some preliminary efficacy of all of these next-generation ALK inhibitors in the brain. This is again data from Dr. Wu's presentation at ESMO, where he showed 4 patients with ALK-positive lung cancer and untreated asymptomatic brain metastases who were allowed to enroll on the alectinib study. And as you can see in each of these paired figures, these patients often had quite dramatic responses in these CNS metastases with very obvious tumor regressions, and many of these responses were also quite prolonged. So just to summarize this section on ALK, based on the phase 1, 2, and 3 studies of crizotinib, crizotinib is now a standard therapy for patients who have advanced ALK-rearranged lung cancer. The strongest data, of course, is in patients who have been previously treated with chemotherapy. However, we have very limited data in the frontline setting, and there will be data from the Profile 1014 study, which may show that crizotinib is also superior to frontline chemotherapy, so that data is anxiously awaited. Unfortunately, patients do, though, relapse on crizotinib, and this is due to the development of acquired resistance. But fortunately, we do have many next-generation ALK inhibitors that are in clinical development, and many of them are showing very promising activity in patients who have relapsed on crizotinib. And finally, I'll just make the point again about the central nervous system being a very common site of relapse, and unfortunately, we even see relapses in the central nervous system in patients who are on the next-generation ALK inhibitors. So now we'll move on to 4 other targets, and we'll probably try to go quickly through these targets. These targets are a little less well established than ALK. Nevertheless, they're very important for us to understand. So the first one that I'll focus on is ROS1. So ROS1 encodes receptor tyrosine kinase like ALK. They're actually very similar. They're very similarly related in the phylogenetic tree of tyrosine kinases, and their ATP binding sites are very, very similar. A number of ROS1 rearrangements have been identified in non-small cell lung cancer, as shown in this slide, but overall ROS1 is distinctly less common than ALK. We see it maybe in about 1% of our cases. But like ALK, ROS rearrangements are also present in other tumor types as well, including GBMs and cholangiocarcinoma. I didn't mention this earlier, but ALK as well as ROS are both associated with some very characteristic clinical features, including younger patients, patients with a never light smoking history, and by and large, almost all of patients with ALK and ROS1 rearrangements have adenocarcinoma histology. We almost never see any overlap between ROS1 and other oncogenic drivers. In fact, we've seen none to date, and in general, these oncogenic drivers do appear to be mutually exclusive. So as I mentioned, ALK and ROS1 are very similar tyrosine kinases, so perhaps it's no surprise that crizotinib can actually inhibit both of these kinases very effectively, and a number of groups have shown that in different cell line models. But now we also have, I would say, very strong clinical data supporting the activity of crizotinib in patients who have advanced ROS1 rearranged lung cancer. This is the latest data that we've presented. This is from the original phase 1 study of crizotinib, and these are patients who enrolled in the ROS1 expansion cohort. So all of these patients were found to have ROS1 rearrangement using a ROS1 FISH assay. And as you can see from this waterfall plot, almost every single patient has had a response to crizotinib, and the numbers below each of the bars indicate the time on study. And as you can see, many of these patients have been on study for a very long time, showing that these responses, again, can be quite significant and prolonged in patients with ROS1 positive lung cancer. This is the latest data on progression-free survival seen with crizotinib in ROS1 positive lung cancer. These patients have been enrolling for a little over 3 years, and many of these patients are still ongoing. In fact, median PFS has still not been reached in this group of patients. And many of these patients actually seem to have quite prolonged response. Some of my patients have been ongoing for over 3 years at this point. But we need to wait. So there will be hopefully an update in the next 6 months or so on progression-free survival. Unfortunately, in ROS1 positive lung cancer, just with ALK and EGFR, resistance does develop, and we've started looking at mechanisms of resistance in ROS1 positive lung cancer. This is a report that our group had published about 8 months ago, looking at a case of ours where a patient had a very dramatic response to crizotinib, as shown in the middle CT scan, but unfortunately after just about 3 months of treatment, her cancer relapsed and almost in the identical location as when she first presented. We were able to characterize her mechanism of resistance, and we identified a novel mutation within the ROS1 tyrosine kinase domain. This led to replacement of a glycine residue at 2032 with an arginine, a very bulky arginine residue, and that's shown here in this structural modeling study, where you can see this large bulky arginine, which is now causing steric interference, and this is believed to be the reason for crizotinib resistance in this particular patients. So again, given what we know about sort of the emerging data on resistance in ROS1 positive lung cancer, we're also looking at some of the next generation ALK inhibitors. It's very interesting that many ALK inhibitors, not just crizotinib, but many of the new ALK inhibitors also have good ROS1 activity, and that's highlighted here in this column, showing that many of them, LDK, the ARET compound 113, as well as the new Pfizer drug 3922, all also have very good activity against ROS1 and may be good next generation options for our ROS1 patients who relapse on crizotinib. So now let's move to the third target, RET. RET stands for rearrange during transfection. RET also is a tyrosine kinase. And again, we've known about RET rearrangements way before we knew about RET in lung cancer. We've known about RET rearrangements in thyroid cancer for many years. And it really was only in the last few years that we had the discovery of RET rearrangements as a potential oncogenic driver in non-small cell lung cancer. Again, similar to ALK and ROS, a number of different RET fusions have now been identified in non-small cell lung cancer. They're shown here. And again, this is a pretty rare abnormality. About 1% of our patients, very similar phenotype as ALK and ROS patients. These tend to be younger patients, never light smokers, adenocarcinoma histology. And again, sort of at the biological level, what happens is these rearrangements result in constitutive activation of the RET tyrosine kinase, and this is what drives transformation of cells. There was a lot of preclinical data showing that these RET rearrangements not only are driving a state of oncogene addiction, but because of that, now conferring sensitivity to a number of RET inhibitors that were actually already clinically available, including vandetanib, sorafenib, and sunitinib. And another one, cabozantinib, has been most extensively studied in the setting of RET rearranged lung cancer. This is a nice study that was published by Dr. Drillon at Sloan Kettering. Cabozantinib is a multi-targeted tyrosine kinase inhibitor that does inhibit RET in addition to other kinase targets as shown here. And Dr. Drillon and his colleagues undertook a phase 2 study to examine the activity of cabozantinib, specifically in patients who were identified as harboring a RET rearrangement. So here's the design of the phase 2 study. All of these patients had to have documented RET fusion, and they enrolled on cabozantinib at 60 milligrams per day. The study is still ongoing, but Dr. Drillon reported preliminary results from this study last year in Cancer Discovery, showing that cabozantinib appears to be active in patients with RET rearranged lung cancer. So here are the 3 patients that he reported on, and at least in 2 of these cases there were responses as shown here, and in the 3rd case there was prolonged stable disease. As it turns out, a large number of other drugs do have RET activity. Many of these are multi-targeted tyrosine kinase inhibitors like cabozantinib, and some of them are shown here. I wanted to point out one in particular, ponatinib, which actually is approved for BCR-ABL positive CML. And ponatinib actually, in addition to inhibiting ABL, does also have activity against RET, and it in fact is or appears to be one of the most potent RET inhibitors. In this study, there will be studies of ponatinib in RET rearranged lung cancer for patients who have failed prior cabozantinib, as well as for patients who are TKI naive. Now let's move to our fourth target, BRAF, and many of you are familiar with BRAF, of course, because of the role of BRAF mutations in melanoma. In lung cancer, we know that BRAF mutations do occur in a small percentage of patients, roughly 2 to 3% of patients, as shown here in this pie chart. The orange slice of the pie represents patients with activating BRAF mutations. Now, there's data presented at ASCO this year of dabrafenib, which is a BRAF inhibitor. It's specific for BRAF V600E. And many of you have seen this data already. This was data on the efficacy of dabrafenib in BRAF mutant melanoma. This is a phase 3 study, and there was dramatic activity of dabrafenib in this population of patients, particularly compared to standard therapy. Now, Dr. Blanchard and his colleagues presented this data at ASCO. This was a phase 2 study. Again, this is an ongoing study. All of these patients had advanced non-small cell lung cancer harboring BRAF V600, the BRAF V600E mutation. These patients were previously treated. And at the time this data was presented at ASCO, they had enrolled 20 patients in the first stage of the study, followed by an additional 20 in stage 2. These are the characteristics of the 25 of those patients that enrolled on the study, and I just wanted to highlight that unlike ALK, ROS, and RET patients, BRAF patients, many of them do have a smoking history. Here you can see that almost 70% of patients did have a history of smoking. So here's the waterfall plot that they presented at ASCO showing activity of dabrafenib in the first 20 BRAF patients with advanced lung cancer. And you can see here a response rate of 40%, a disease control rate of 60%, suggesting that in BRAF mutant lung cancer, BRAF is yet another target and one that can be effectively targeted by dabrafenib. Here's additional efficacy data showing, again, the 40% response rate. 20% of patients did have stable disease, and just a minority, 30% of patients, had progressive disease as the best response. Duration on treatment was impressive and ongoing for many patients. Here you can see months on the x-axis, and many patients who achieved a partial response had very, very durable responses. And so to summarize BRAF, dabrafenib does appear to have activity in BRAF V600E mutated non-small cell lung cancer. There weren't any new safety signals that were seen with dabrafenib in this study. And actually, based on this data, which is actually quite limited, dabrafenib did very recently receive FDA breakthrough therapy designation. The study is ongoing, as I mentioned, but it has been amended and actually will now include the combination of dabrafenib with a MEK inhibitor, trametinib. So finally, I'm going to end on KRAS, and KRAS is the most common mutated oncogene in human cancer, and in lung adenocarcinoma as well. Mutant KRAS is the most common oncogene, but unfortunately KRAS has proven to be very refractory to targeting over the years. Shown here is just, again, the pie chart highlighting that we find KRAS mutations in close to 1/4 of our patients. We do know that KRAS mutations are more common in patients with a smoking history. This is just data from 4 large studies looking at KRAS mutations by smoking status, and just highlighting that many of the KRAS mutant patients have a smoking history. And then I also just wanted to highlight that KRAS is quite complex. There are many different KRAS mutations affecting codons 12, 13, as well as 61. In addition, there can be other mutations that occur along with KRAS, including in P53 and LKB1. So although we show a slice of the pie as KRAS, we suspect that that slice of the pie is actually quite heterogeneous. And this may in part explain the difficulty in targeting KRAS over the years. So I just want to highlight one study of selumetinib in KRAS mutant lung cancer. This is really the only study that has shown a potential benefit of a targeted therapy in KRAS mutant lung cancer. And so this is a study of, this is a phase 2 study that Dr. Yanni presented at ASCO. And this study combined docetaxel with selumetinib. It was a randomized phase 2 study, so some patients received the combination standard dose of docetaxel at 75, and others just received docetaxel with placebo. The study was on the smaller side, about 40 patients in each arm, and the primary endpoint was overall survival. Here you can see that overall survival, there was definitely a trend toward overall improvement in overall survival with the combination of selumetinib with docetaxel. Median OS was 9.4 months, and that's compared to 5.2 months. However, that did not reach statistical significance, so the primary endpoint of the study was actually not met. But I did want to show you that for progression-free survival, as well as for response rate, there was a statistically significant improvement with the combination. Here, the median PFS was 5.3 months with the combo versus 2.1 months. And the response rate was strikingly different, with a response rate of 37% with the combination versus actually 0% with single-agent docetaxel. Now, this combination does look promising in terms of the data we've seen so far. However, the adverse events, I think, were also quite striking. This combination is somewhat difficult to tolerate for patients, as you can see here. And I just wanted to highlight that one of the most common side effects that were seen was neutropenia, and there was a fairly high rate of hospitalization due to febrile neutropenia. So I think this combination does have some promising efficacy, but the side effect profile will need to be addressed. And so that combination of selumetinib, a MEK inhibitor with docetaxel, is promising, but I also wanted to point out a few other strategies that are already ongoing in the clinic, and these primarily involve combining two targeted therapies. MEK inhibitors with PI3 kinase inhibitors. I've summarized 6 ongoing studies that you may hear about. So just to keep an eye out for these studies, which really are focused on the KRAS mutant population. Okay, and I'll end there and turn it back to you.
Very good, Alice. Thank you so much. That was an exhaustive, rapid run through a lot of really interesting topics, and we appreciate it. So we'll take a break here again and come back in just a few minutes, and Dr. Mark Christ from Memorial Sloan Kettering will bring us up to date on some of the molecular developments in squamous cell carcinoma and maybe a little on small cell as well. So thanks for watching this portion of Opinion Leader Workshop in non-small cell lung cancer.